This week for EMN5, we're going to talk about some different treatments for hypertensive emergencies. So first, let's go through a couple definitions. First, we have hypertensive urgency versus emergency. For hypertensive urgency, it basically means the blood pressure is high, but really there are no other symptoms that the patient has, maybe mild headache. In hypertensive emergency, it means that the blood pressure is high, usually we say kind of 180 over 110, plus some evidence of end organ damage. And that can be in a lot of different areas, brain, heart, kidneys. So things we're going to look for in the emergency room is high blood pressure plus maybe blurred vision, altered mental status, seizures, stroke, so some kind of focal neurodeficit, chest pain, shortness of breath, renal failure, all these different things. Okay, so now we have a patient. We're concerned about hypertensive emergency. Let's talk through a bunch of different scenarios. I'm going to give you a case, and then we'll talk about which hypertensive emergency we're dealing with, and then talk about what treatment is appropriate for each case. So let's start off with, we're transporting a 67-year-old male, has a history of hypertension, we're called for respiratory distress. The patient is statting pretty low in the 80s, pretty hypertensive. Pink frothy sputum, tripoding, you just hear crackles all the way up to their chin. They have pitting edema in the legs. What do you think we're dealing with here? Good, so this would be an acute CHF exacerbation. So what we're going to use for treatment here are nitroglycerin. You can either do the sublingual or do a patch, and then once you get in the ER, you could even put them on a drip. You want to give them Lasix to help diurese, and also probably put them on BiPAP to help push the fluid out of the lungs. Things we do not want to use here are beta blockers. All right, next case. We have a 36-year-old female. We're called for seizures. She has a blood pressure of 145 over 80, so not too bad. But she's still seizing despite 3 times of Ativan, and so we do decide to intubate her. What are we missing here? Young, female. Yeah, so we need to ask about pregnancy status, right? And as the husband then informs us, she is 1 week postpartum. So now let's think back. Is that blood pressure high for a female who's just postpartum or pregnant? Yeah, it is. And here's what we're dealing with here is eclampsia. So in this case, our treatment is going to be magnesium. So you're going to give 6-gram load IV. You can also give labetalol, hydralazine, and nicardipine are all good options to help lower the blood pressure. And really, if the patient's still pregnant, the other big treatment is just to get her delivered. The medication to avoid here is going to be nitro. Okay, next case, we have a 78-year-old female. She has crushing chest pain for the last 30 minutes. She's pretty hypertensive. We do an EKG in the field, and it reads STEMI. So she's coming into your ER. What are you going to do? First off, we're concerned that this is ACS, right? She's having a heart attack. So our medications we're going to use here are going to be nitroglycerin. Again, we can give this sublingual. It's probably a good option. We should also treat her pain. So giving her morphine can help and bring that blood pressure down a little bit. And you can also consider giving a beta blocker. Things to avoid here are going to be hydralazine. All right, next case, we have a 75-year-old male. Now, this is the patient we're going to be evacuating to the nearest cardiothoracic surgery center because his chest x-ray looks like this. He's in a lot of pain, and his blood pressure is 140 over 90. So first off, what's going on here? Yeah, so this is an aortic dissection. Now, we talked about high blood pressure before. What do you think of this one? 140 over 90. Now, in this case with aortic dissection, that is considered a high blood pressure. And our whole goal is to keep the blood pressure low and the heart rate low to decrease the shearing forces for the aortic dissection. So our goal blood pressure is actually going to be really low. It's like 90 to 110, and the heart rate should be down 60s to 70s. So medications we want to use, beta blockers are a great choice. Asmolol works very well. You can use labetalol. If the blood pressure is still not coming down despite starting an asmolol drip, your next choice might be sodium nitroprusside. You do want to avoid hydralazine. The other thing to think about is pain control in these patients because that can do a lot to bring their blood pressure and heart rate down. All right, next we have a transfer to a stroke center. This is a 46-year-old female. She's intubated for a hemorrhagic stroke. Blood pressure is 180 over 110, heart rate of 75. So we already know what this is. It's a hemorrhagic stroke. Now, what is our goal blood pressure here? Here's the categories I always think about with a stroke. We have to differentiate which type of stroke we're dealing with in order to decide what our blood pressure goal should be. If it's a hemorrhagic stroke, our goal is going to be lower, right? Your blood pressure here, systolic, should be less than 160. Now, ischemic, you have to divide into patients that are eligible for TPA and those that aren't. If they are eligible for TPA, your blood pressure goal should be less than 185. If they're ischemic stroke, but they're not going to be getting TPA, we really want to do our best to increase the blood flow to the brain. So you're going to allow permissive hypertension up to 220. So in our hemorrhagic stroke patient, remember our goal is less than 160. We're going to be giving labetalol. This is a good option, or also starting a nicardipine drip. You do want to avoid hydralazine in this situation. All right, so here's just a quick chart that shows a brief overview of all the different medications we talked about and things to avoid along with their dosing. Here's the references, and thanks for joining us this week on EMN5.